इसमें Hello guys, I am Dr. Himanshu Gupta and I am your radiology faculty on Medway online. So today I am going to discuss few important questions as well as images that will be helpful for you in your upcoming exams, right? So guys, if I am audible to you, please let me know in the comment section in the chat. Just let me know if I am audible to you. So guys, beginning with the first question, a patient presented with pleuritic chest pain and absent breath sounds on the right side. What is the best X-ray to diagnose this condition, right? So the patient is having chest pain and hi Dr. Bemisal. So pleuritic chest pain and absent breath sounds, your diagnosis is a case of pleural effusion. Now pleural effusion can be diagnosed on the chest X-ray PA view, right? So what is the sign that you are going to see in pleural effusion? Anyone? What is the sign that you are going to see in pleural effusion? You will see that there will be blunting of costophrenic angle. Now the question that is asked, what is the amount of effusion that is needed to cause blunting of the CP angle? So this blunting of CP angle happens when there is approximately 150 to 200 ml of pleural fluid, right? Now if we have to detect any effusion before that, right? So your lateral decubitus view is the best view to diagnose pleural effusion on the X-ray, right? So it can detect up to 50 ml of pleural fluid, right? Now another question that is asked on pleural effusion is, what is the best investigation to detect pleural effusion? Anyone guys? Best investigation to pick up pleural effusion. So this is your ultrasound. Ultrasound is the best investigation to pick up pleural effusion. So guys, there is a thumb rule that you need to remember, that if you have to pick up fluid anywhere in the body, whether it is pleural effusion, whether it is ascites, then USG is the investigation of choice. If you have to pick up air anywhere in the body, whether it is pneumothorax, whether it is pneumoperitoneum, then what is the best investigation of choice to pick up these conditions? Can anyone tell me? It is non-contrast CT. If you have to pick up pneumothorax, again your non-contrast CT, okay, will be the investigation of choice for pneumothorax, peritoneum also, and for pneumomediastinum also, right? So now coming to the next X-ray, okay, next question. A patient presented with pleuritic chest pain and absent breath sounds on right side. Okay, sorry. The chest radiograph of a patient showed silhouetting of the left border of the heart. Pathology of which part of the lung does this indicate, right? So if these are your two lungs and this is your heart, right? So what does silhouette means? So on a chest X-ray guys, you will see that heart has very sharp borders with the adjacent lung. So if there is a consolidation, right, in the right middle lobe, for example, so what it will do? It will obscure your right heart border, right? So this loss of borders of the heart, this is known as silhouetting. Now in the question we have been asked, So if there is silhouetting of the left border of the heart, okay, so which part of the lung is involved? So it is your lingular segment which is involved, right? In case of right lower lobe, what you will see, that there will be silhouetting of the right dome of diaphragm, and same with the left lobe. If there is silhouetting of the left dome of diaphragm, you will see that there is a consolidation / collapse in the left lower lobe, right? So there are few important named signs that you need to remember as well as collapse is concerned, right? So can anyone tell me what are you able to see in the first image? Anyone, guys? So in the first image, you can see that there is a homogeneous opacity in the left lower zone, right, in the retrocardiac area, and this homogeneous opacity in the left lower zone behind the retrocardiac area, what it is doing, it is due to the collapse of the left lower lobe, right? And what is the name of this sign? It is the flat waist sign, right? Right? Now guys, let us have a look at the image B, right? Image B. What are you able to see on this image B? Anyone, guys? What are you able to see on the image B? So in the image B, guys, what we can see is that there is a homogeneous opacity in the left upper zone, right? And this homogeneous opacity in the left upper zone, right? And along with that, guys, you can see that there is a sickle shaped air around the arch of aorta. A sickle shaped air can be seen around the arch of aorta. So this is known as Luft-Sichel sign, right? Luft means air and Sichel means sickle shaped. So this Luft-Sichel sign, it is seen in left upper lobe collapse. Now talking about the third image. In the third image, what we can see, that there is a homogeneous opacity in the right upper zone and it is taking the shape of an S. It is taking the shape of an S, and this is known as golden S sign. And this golden S sign, it is seen in patients with right upper lobe collapse, right? And homogeneous opacity in the right middle zone, okay, that is obscuring your right heart border. This is your Silhouette sign seen in right middle lobe collapse, right? So in which of the following conditions you will not see an air bronchogram? So guys, air bronchogram, what is air bronchogram sign? You will see a homogeneous opacity, and within that homogeneous opacity you will see linear translucencies. So this is known as air bronchogram sign. This is classically a sign of a patient with consolidation. So what happens in consolidation? Your alveoli gets filled with blood, pus or fluid, right? So this will be seen in consolidation. It is also seen in pulmonary edema, hyaline membrane disease, right? But your pleural effusion, it is not going to show your air bronchogram sign, right? Dr. Tawfiq Ahmed, which of the following is true regarding curly A lines? So very important question, curly A lines, curly B lines, curly D lines, right? So if I draw the heart, this is your heart, this is your lung, okay? So curly B lines, you all know this is seen in congestive heart failure. These are perpendicular lines to the pleural surface, right? Curly B lines. So if these similar lines are seen along the hilum, okay, these are known as curly A lines. If I take a lateral radiograph and I look at the curly B lines, that will be your curly D lines seen in the retrosternal area. And besides these, all other lines seen anywhere within the lung, these are your curly C lines. So now let us have a look at the question, which of the following is true regarding curly A lines? So these curly A lines, guys, these radiate from the hilum of the lung. So this is your curly A lines. Lines running perpendicular to the pleural surface, these are your curly B lines. Has spider web appearance, this is your curly C line, okay? Short lines which do not reach out to the pleura, right? So guys, other important signs that you are going to see in congestive heart failure, okay, it will be your cephalization of vessels, then you are going to see cardiomegaly, then you are going to see perihilar consolidations that give a bat wing appearance, right? And third, you are going to see bilateral pleural effusion, right? And along with that, you are also going to see curly B lines, right? So important finding that you are going to see in congestive heart failure. Pleural calcification can be seen in all the patients except, so we all know that pleural calcification is characteristically seen in patients with asbestosis. In asbestosis, you are going to see pleural plaques which are identified as patchy areas of calcification. Now besides asbestosis, guys, this pleural calcification can occur when your hemothorax, okay, within a hemothorax, after it healed empyema, but in sarcoidosis you are not going to see any pleural calcification. So what are you going to see in sarcoidosis? You will see perihilar calcified lymph nodes, okay. So calcific lymphadenopathy will be seen in sarcoidosis, right? And they are going to give a panda sign on gallium scan. So just remember these two important things. Gallium scan, they are going to show a panda sign. So guys, can you tell me where else you are going to see this panda sign? Any other place where you are going to see this panda sign? So this panda sign, it is also seen in patients with Wilson's disease, right? So a cystic lesion, okay, these are few important questions within the chest radiology. Now a cystic lesion in the suprasellar region with calcification is seen on the MRI. What is the most likely diagnosis, right? So guys, if I talk about pituitary adenoma, it is a cellar as well as suprasellar region, What is the imaging appearance of pituitary macroadenoma? Okay, it gives a figure of 8 or snowman appearance, right? Talking about meningioma, so meningioma has characteristic sign which is known as dural tail sign, and it is an extraaxial lesion, right? Oligodendroglioma, okay, it is an intraaxial lesion, okay, and it is going to show calcification, but it will not be seen in the suprasellar location, right? So your answer will become craniopharyngioma, seen in children, right? Craniopharyngioma is seen in children. It is a solid cystic lesion, right? And just remember that 90% of the lesions are cystic, 90% of the lesions are going to show calcification within them, right? So let us talk about the most common tumor, most common brain tumor. Can anyone tell me which is the most common brain tumor? So this is your most common brain tumor is your metastasis, right? Most common intraaxial brain tumor, intraaxial primary brain tumor, it is your glioma. Most common extraaxial primary brain tumor is it is your meningioma, right? Most common brain tumor to show calcification, it is your craniopharyngioma. So these are few most common that you guys need to remember, right? So guys, these are two images, image A and image B. So guys, can you tell me what is your diagnosis for this case? Image A, what brain tumor are you able to see in the image A? So if you look at the image A very carefully, you will see that this tumor, it is surrounded by a cleft of CSF on all sides. So this cleft of CSF on all sides, this is known as CSF vascular cleft sign, and this CSF vascular cleft sign, this is seen in patients with meningioma. CSF vascular cleft sign is seen in patients with meningioma, right? Now talking about the second tumor, okay, the second image. In the second image, we can see that there is a lesion which is located in the sella and suprasellar location. This lesion is located in the sella and suprasellar location, and it is showing avid contrast enhancement, and along with that we can see the shape of the appearance is snowman appearance or figure of 8 appearance. So this figure of 8 appearance, this is seen in a case with pituitary macroadenoma, right? Pituitary macroadenoma. Now coming to the next image, bracket calcification on skull X-ray is seen in which of the following condition? So just remember that this bracket calcification is due to the calcification in the lipoma of corpus callosum, which is going to show bracket shaped calcification, right? If I talk about important features of each of these tumors which are mentioned here, in tuberous sclerosis you are going to see subependymal nodules, right, in brain, okay, and you are going to see subependymal giant cell astrocytoma in patients with tuberous sclerosis. If I talk about von Hippel-Lindau syndrome, within the brain what you are going to see? You are going to see a hemangioblastoma. And this hemangioblastoma has a characteristic appearance which is known as cyst with a mural nodule. So I am going to show this appearance, right. So guys, can you name one tumor which has a butterfly shaped appearance? Butterfly shaped tumor. It is glioblastoma. Ice cream cone appearance is seen in the CP angle tumor, which is your acoustic schwannoma. Right. So these are important tumors which have characteristic shapes or appearances which you guys should know, right. Acoustic schwannoma. ठीक है. So guys, this is the appearance which I was talking about, okay. So here we can see that there is a cystic lesion, and within this cystic lesion you can see that there is a solid component, that is your nodule. So this appearance is characteristically shown by few tumors which you guys should know. One is pilocytic astrocytoma, then it is shown by ganglioglioma, then pleomorphic xanthoastrocytoma, and it is also shown by hemangioblastoma. So name of this appearance is cyst with a mural nodule. Right. Now a 7-year-old boy is brought to the pediatric OPD by his parents with complaints of headache. What is the most probable diagnosis by looking at this image shown below? So guys, here we can see that there is a mass lesion seen involving the fourth ventricle, okay, and it has a homogeneous appearance, right. So the most common primary brain tumor in children, this is a case of medulloblastoma, right, medulloblastoma. So if I need to compare medulloblastoma from ependymoma, okay, so just remember that this medulloblastoma, it is going to arise from the roof of the fourth ventricle. Ependymoma will arise from the floor of the fourth ventricle. Hemorrhage, calcification, this is more common in ependymoma, whereas it is less common in medulloblastoma. So medulloblastoma, it is a more homogeneous tumor and it is going to appear hyperdense on the CT images. Talking about arachnoid cyst, right. So arachnoid cyst, it is a cystic lesion, and this cystic lesion, guys, it is going to suppress on FLAIR images. So here this lesion is T2 heterogeneously hyperintense, but an arachnoid cyst, guys, it will have a signal intensity that of CSF. Whereas if I talk about epidermoid cyst, okay, so epidermoid cyst, it is a lesion, it is again a cystic lesion which shows, can anyone tell me how to differentiate arachnoid cyst from epidermoid cyst? So just remember that epidermoid cyst, it is going to show diffusion restriction on DWI images, and it does not show complete suppression on FLAIR images, right? So a 60-year-old woman presented with hearing loss, right? What is the most probable diagnosis? So here we can see that these are the contrast enhanced MRI images of the brain, and we can see that there is a heavily enhancing lesion. Very good Tausif Ahmed. Avidly enhancing lesion seen in the right CP angle, and it is giving the ice cream cone appearance, which is known as this tumor is vestibular schwannoma, right? So now guys, you have to tell me, okay, one syndrome which is associated with vestibular schwannoma. Can anyone tell me which is that one syndrome? So that is your neurofibromatosis 2. Okay. So neurofibromatosis 2 can be remembered with a simple mnemonic, that is miss me. So in neurofibromatosis 2, you are going to see multiple inherited schwannomas, meningiomas and ependymomas, right? So this is an important feature of, these are the few important features of neurofibromatosis 2. So patient presented with cognitive deficit, involuntary hand and finger movements and muscle incoordination. So on MRI of the brain, you will see that the shape of the ventricles, okay, it is the shape of a, these are your boxcar shaped ventricles, right? And this boxcar shaped ventricles, very good, and Dr. Tausif, these are seen in patients with Huntington's disease, right? And in Huntington's disease, just remember that you are going to see CAG repeats, right? So this is another question that is asked in your exams. And this boxcar shaped ventricles, it is due to the atrophy of the caudate nucleus, atrophy of caudate nucleus. So here in this patient, we can see that this is your caudate nucleus, right? And in this caudate nucleus, we can see there is atrophy of the same, right? So a T2 weighted MRI was done for a child who presented with delayed milestones, right? And on these T2 weighted images, we can see that there is bilateral symmetrical hyperintensity in frontal white matter. So guys, can you tell me what is the likely diagnosis in this case? Anyone guys who can tell me? So guys, this is a case of Alexander disease. So guys, we should know how to differentiate all these leukodystrophies. So guys, if there is a hyperintensity in the bilateral cerebral hemispheres, and it is giving the tigroid appearance, right? दोनों जगह हाइपर इंटेंसिटीज है, दोनों सेरेब्रल हेमिस्फीयर्स में है, बट इट इज स्पेयरिंग योर सबकॉर्टिकल यू फाइबर्स. So that is seen in a case of metachromatic leukodystrophy. So this is your T2 video images of the brain, and here you can see these are your asymmetrical hyperintensities, है ना. इसमें ये hyperintensities these are giving the tigroid appearance, right? And in the first image you can see that these hyperintensities, these are again present in bilateral hemispheres, and it is also involving your subcortical U fiber. And if I talk about MRS, it is going to show increase in NA levels on, it is going to show increase in choline levels. So this is seen in a case of Canavan's disease, right? Canavan's disease, right? Now this third image, this was asked in your question. You see that there are bilateral symmetrical hyperintensities in the frontal lobes. So this is your case of Alexander disease. Very good. In Canavan, okay, you see, so Na levels are increased, and in the last image, guys, we can see that hyperintensities are present posteriorly in the parieto-occipital white matter. So that will be seen in a patient with X-linked adrenoleukodystrophy, right? Now guys, trauma में important imaging appearances let us discuss, right? So how to identify a bleed? Okay, what is the investigation of choice in patient with trauma? It will be your NEET head. In patients with acute stroke, okay, your investigation of choice will be MRI. So why investigation of choice is NEET head? Because it takes less time, and if there is any hemorrhage within the brain, it can be identified, right? So let us try to identify the bleed based on its appearances. So if the shape of the bleed is, if the shape of the blade is biconvex, it is due to the rupture of middle meningeal artery, and it is seen in patients with extradural hemorrhage. Clear? Right? And if there is a biconvex shape bleed, if the shape of the blade is concavo-convex, that is seen in patients with subdural hemorrhage, right? And just remember that this subdural hemorrhage, it is seen in old age patients, in alcoholic patients, and it is due to the rupture of cortical bridging veins. Cortical bridging veins, right? Very good. It is biconvex shaped or it is concavo-convex shaped, right? And in the third case, guys, what we are seeing, that there is a bleed, okay, there is a bleed which is surrounded by a rim of hypodensity, So this is your hemorrhagic contusion. And if the shape of the bleed, okay, it is taking the shape of the basal cisterns, or if there is any bleed in the sulcal spaces, that will be seen in a patient with subarachnoid hemorrhage. And just remember that this subarachnoid hemorrhage, it is due to the rupture of aneurysm of the intracranial vessels. ठीक है, rupture of aneurysm of intracranial vessels, right? Now, so this is a patient with history of, okay, left sided hemiparesis. So I told you, in patients with acute stroke, your investigation of choice will be MRI. And on MRI, what you will see, on diffusion weighted images, there will be a hyperintensity, right? So these are the diffusion weighted images showing hyperintensity on DWI, dark on ADC maps, right? Dark on ADC maps, and again hyperintense on FLAIR images. So these are the features of acute infarct. Just remember this, right? So guys, third case, again it is a very important case. So it is nowadays being asked in your exams. So patient with history of RTA has altered sensorium and NCCT head is normal. You do an MRI for this patient, and on MRI you will see that there are multiple foci of blooming. Multiple blooming foci are seen on SWI images. So this is a typical case of diffuse axonal injury, right? So this is one case of trauma where you can see that NCCT head is completely normal, and only your imaging findings are seen on the SWI images or MRI, where you are going to see black dots, right? So hyperacute ischemic stroke के कुछ important signs that you guys should know. So first one is the hyperdensity along MCA. This is known as dense MCA sign. Hyperdensity along the Sylvian fissure. This is known as Sylvian dot sign. Hyperdensity along the basilar artery, dense basilar artery sign, right? Then loss of insular ribbon sign. You can see that this insular cortex okay, normally the insular cortex is visible in a normal patient, but when this insular cortex is not visible separately, this is loss of insular ribbon sign. And the last sign is disappearing basal ganglia sign. So few important signs that you should remember as far as acute stroke is concerned, right? Hyperacute ischemic stroke is concerned. Which of the following findings are you unlikely to see in a patient with achondroplasia? So guys, in achondroplasia, you are going to see bullet nose vertebra, you are going to see chevron sign in the epiphysis, trident hand, inferior beaking of the vertebra. This is not seen in achondroplasia. Right? So just remember that in achondroplasia, patients will be dwarf, okay? They will have a rhizomelia. It means that there will be shortening of proximal limbs. Right, and if I talk about chevron sign in the epiphysis, okay, trident hand, so there will be gap between the third and fourth fingers, right, and bullet nose vertebra, again which is a characteristic sign that you are going to see in the achondroplasia. So if I talk about inferior beaking of vertebra along with J-shaped sella, this will be seen in patients with Hurler syndrome, right. Increase in the density of bones, diffuse increase in the density of bones, okay, bone within a bone aberrance, bone within a bone aberrance. This is seen in patients with, just remember, osteopetrosis, again can be asked in your exam, right. Then long fingers, that is known as arachnodactyly, along with aortic dissection. This is seen in Marfan syndrome, right. Long fingers with aortic dissection, Marfan syndrome. Absent clavicle is seen in cleidocranial dysplasia. Right, absent clavicle is seen in cleidocranial dysplasia. Posterior iliac horns, these are seen in patients with nail patella syndrome, right. ठीक है. So a radiograph of a child with history of delayed walking showed the following findings. What is the likely diagnosis? So guys, this is an X-ray of the wrist. What you can see in this wrist, there is widening of the metaphysis, okay, there is cupping of the metaphysis, and along with that we can also see that there is fraying of the metaphyseal end. So this characteristic triad of cupping, widening and fraying of metaphysis, this is seen in patients with rickets. Very good, very good. Marfan syndrome, I have already told you, you are going to see arachnodactyly. Talking about osteogenesis imperfecta. So in osteogenesis imperfecta, you will see that the patient is having blue sclera, there will be osteopenia, and you will have multiple fractures in the various bones. So this will be the characteristic finding as far as osteogenesis imperfecta is concerned. And talking about rickets, so rickets again has very characteristic findings. You are going to see subperiosteal hemorrhage, you are going to see tense zone of provisional calcification, that is your white line of Frankel. You are going to see again a hyper radiodensity around the epiphysis, Wimberger ring sign, and you are going to see Pelton's spur. Again very important finding for your scurvy. Okay, so rickets or scurvy should be clear to you. What is the earliest sign of left atrial enlargement? on a chest X-ray. So earliest sign is enlargement of the left atrial appendage. So other signs that you are going to see in left atrial enlargement. So just remember that this left atrial enlargement is seen in patients with mitral stenosis, right? Mitral stenosis. And the important signs that you are going to see in patients with L enlargement will be your double density sign or double right heart border. Okay. So what normally happens in a patient, you will see that there is a single right heart border that is seen on a chest X-ray, but in these patients you will see that there will be two right heart borders. So that is your double density sign. You will see that there will be widening of the carinal angle. So in a normal patient, this angle is less than 90 degree. So when the angle is more than 90 degree, that will be seen in patients with left atrial enlargement. Okay. Then you will see that your left heart border, it will get straightened. Again a sign of left atrial enlargement. And last important sign is walking man sign, that is seen on a lateral radiograph. ठीक है. So you should know what happens in RV enlargement. In this you will see that the apex of the heart, it is going to shift upwards. In LV enlargement, you will see that the apex of the heart, it will shift laterally and inferiorly. So these are important signs of left ventricular enlargement. ठीक है. RV hypertrophy or enlargement, you guys all know, it is seen in patients with tetralogy of Fallot, right? So the chest X-ray of a child who presented with progressive breathlessness is given below. What is the likely diagnosis? Anyone in the comment section? Chest X-ray of a child who is cyanotic, presenting with progressive breathlessness. What is the shape of the heart that you are able to see in this image? The shape of the heart is a boot shaped heart. Very good. Boot, seen in patients with tetralogy of Fallot, right? And what are the four things that you will see in these patients? There will be infundibular stenosis, there will be right ventricular hypertrophy, there will be overriding of aorta, and you will see there will be a ventricular septal defect. ठीक है. तो कुछ important imaging appearances let us discuss. So first is the egg on string appearance. So this egg on string appearance, this is seen in patients with transposition of great arteries. Second image, image B, you can see that this is the snowman appearance or figure of 8 appearance, seen in patients with total anomalous pulmonary venous connection, in which all the pulmonary veins, they are draining into the right atrium instead of left atrium, and it can be of various types, type 1, 2, 3, 4. Okay, in type 1 you will see all the pulmonary veins, these are draining into the SVC. In type 2 all the pulmonary veins, right, these are either draining into the right atrium or coronary sinus. And in type 3 you will see all the pulmonary veins, these are draining into the IVC. And type 4 can be a mixed type, right? Now talking about this image, okay, this is again a tetralogy of Fallot boat shaped heart, right. In the third image we can see that there is a constriction in the arch of aorta, okay, giving a figure of 3 appearance. So this is seen in patients with coarctation of aorta, in which you will see that there will be narrowing in the arch of aorta, and another sign that you are going to see in these patients will be your inferior rib notching, right. And third, fourth is the box shaped heart that is seen in patients and females who have had history of lithium use, and this is your Epstein anomaly, in which you will see that there is inferior displacement of the tricuspid valves, leaflets, and there is a gross RA enlargement along with smaller right ventricle, right. Chalo, next X-ray. So 52-year-old woman presented with pain in the wrist following a fall on the outstretched hand. On examination, tenderness was noted in the anatomical snuff box. A radiograph of her wrist is given below. So what are you able to see on this radiograph of the wrist is that there is gap between the scaphoid and the lunate bone. So this gap between scaphoid and lunate, it is seen in scapholunate dislocation. Very good, Dr. Tausif. Scapholunate dislocation. This is also known as Terry-Thomas sign. Which of the following conditions is least likely to cause the following appearance? Okay, so here I have just forgot to bring the image for you. So this was an Erlenmeyer flask deformity, where you will see that there will be widening of the limbs, known as Erlenmeyer flask deformity. So this is seen in all of the conditions except, so it will be seen in Gaucher's disease, thalassemia, leukemia, but it will not be seen in a patient with Hunter's disease, right. So a child presented with pain in the leg, pain and swelling in the leg, X-ray is given below. What is the most likely diagnosis? What is the most likely diagnosis? So if you look at this X-ray very carefully, you will see that there is an onion skin peel appearance, okay, type of periosteal reaction. So this onion skin peel type of periosteal reaction, this is seen in patients with Ewing's sarcoma, right. If I talk about osteosarcoma, this is seen, what does it show? Sunray appearance, right. More common in children less than 10 years of age. Giant cell tumor, it is common in between 20 to 30 years of age. It is an epiphyseal tumor, okay. And unicameral bone cyst, you will see cystic lesion, right. And it gives an important sign which is known as fallen fragment sign, ठीक है. तो बोन ट्यूमर्स के बारे में लेट अस डिस्कस फ्यू इम्पोर्टेंट थिंग्स, राइट, बेस्ड ऑन एज, okay. if I talk about bone tumors which are common in more than 40 years of age, so this includes your chondrosarcoma, your metastasis, and your multiple myeloma. If I talk about tumors between 20 to 40 years of age, you have enchondroma, okay, you have giant cell tumor, and you have parosteal osteosarcoma. And tumors more common in less than 20 years of age, this includes your various cysts, okay, then you have your Ewing sarcoma, osteosarcoma, right? All these tumors, osteoid all these tumors are common in less than 20 years of age. Then based on location, okay, you should know there are tumors which are common in the epiphysis, epiphyseal location. So the tumors common in the epiphyseal location, this include your E, C and G, where C and G stands for chondroblastoma and giant cell tumor, right? Tumors common in the diaphyseal location can be remembered with a simple mnemonic, that is coffee, right? So C for cyst, O for osteoid osteoma, F for fibrous dysplasia, E for Ewing sarcoma, and E for enchondroma, right? So these are tumors which you should remember based on their location. Then you should also remember tumors based on their appearance, okay. So if a tumor is showing this onion peel type of periosteal reaction, you are going to think of Ewing sarcoma. If a tumor it is going to show a sunray type of periosteal reaction, you are going to think of osteosarcoma, right? Then if a tumor, okay, if a tumor it is well defined, okay, you are going to think of a benign lesion. If a tumor has a wide zone of transition or an ill-defined appearance, you are going to think of malignant bone tumor, ठीक है. And सबसे important question, if I talk about, you guys should know how to differentiate between chondroblastoma versus giant cell tumor. So just remember that both these tumors, these are found in the epiphyseal location, right? But in chondroblastoma, the age will be less than 20 years, the growth plates will be unfused, right? Whereas in giant cell tumor, age will be more than 10 years and growth plates will be fused. So this is the important difference that you should remember between chondroblastoma and giant cell tumor, right? So here again in the first image we can see that there is an exophytic growth from the bone, okay. So this is a case of osteochondroma, and you should know that the medulla of the parent bone, it is continuous with the medulla of the tumor, and there are few features which are going to suggest features of malignancy in this osteochondroma. This is, one is first, thickness of cartilaginous cap by more than 3 cm, pain within this tumor, or growth after skeletal maturity. So these three important features, these are going to suggest transformation of this benign tumor into a malignancy. And the most common tumor, okay, malignant tumor that occurs after osteochondroma is chondrosarcoma. ठीक है. अब एक lytic lesion है. Now there is a lytic lesion, right, in the calcaneum of the bone. So this lytic lesion in the calcaneum of the bone, this is the case of intraosseous lipoma. And third, you can see that this is a case of you can see that there is a lytic lesion involving the epiphysis and the growth plates of this tumor are unfused. So this is a case of giant cell tumor, right, giant cell tumor. ठीक है. Now guys, let us have a look at few barium images. So barium swallow of a patient presenting with dysphagia is given below. What is the most likely diagnosis? So here you can see that what is the shape of this esophagus, right? So this characteristic shape of this esophagus, it is seen in patients with diffuse esophageal spasm. Okay, you have an undulating appearance of the esophagus. You can see contractions at various levels within the esophagus. Contractions at various levels within the esophagus. This is diffuse esophageal spasm. Now let us have a look at various other appearances also, right? So this smooth narrowing of the distal esophagus, this is seen in patients with benign stricture, okay, of the esophagus after corrosive ingestion, right. The first image is that of esophageal web. It is associated with Plummer-Vinson syndrome. ठीक है. Third image, you can see that there is a diverticulum. The patient will present with halitosis and there is a diverticulum arising from the posterior aspect of the esophagus, right. So this is your Zenker's diverticulum. And you see that there is a outpouching from the lateral aspect of the esophagus, okay, that is your Killian-Jamieson diverticulum. As far as achalasia cardia is concerned, you will see that it gives a bird's beak appearance. Bird's beak appearance. ठीक है. In esophageal cancer, you are going to see that there will be a rat tail appearance. ठीक है. Important, ये सारे important हैं. सारे barium swallow के images all are important. ठीक है. Now again a question on the barium swallow. A woman presented to the OPD with dysphagia and regurgitation of food. She was diagnosed with iron deficiency anemia 3 months back. Barium swallow was done. What is the most probable diagnosis? So you see there is an esophageal web, okay. The patient has dysphagia, regurgitation of food, right. So this linear defect within the esophagus, this is seen in a patient with esophageal web, right. So esophageal web with dysphagia and iron deficiency anemia, this triad, it is seen in patients with Plummer-Vinson syndrome, right. What is Bohr syndrome? Okay, in Bohr syndrome you will see that there will be rupture of the distal esophagus due to excessive vomiting. Okay, the patient will have chest pain, subcutaneous emphysema, and you will have excessive vomiting. And because of this excessive vomiting, there is rupture of the esophagus. If you do barium swallow for this patient, okay, you will see that there will be leakage of contrast into the mediastinum and into the lungs, right? And also you will see pneumomediastinum in these patients. So a 6-week-old child presented to the emergency with non-bilious projectile vomiting. On USG, the following observation was made. What do you suspect? So on USG, you will see that this patient, okay, this patient is having thickening of the pylorus. Okay, there is thickening of the pylorus. And you will see that this thickening is extending for a length of more than 16 mm and the thickness is more than 4 mm. So this is the characteristic feature seen in patients with congenital hypertrophic pyloric stenosis. In jejunal atresia, you will see the double bleb sign, right? Double bleb sign will be seen in jejunal atresia. And ileocecal tuberculosis, just remember important signs that you are going to see. So this includes your Sterlin sign, in which there is a rapid emptying of the involved bowel loop. There will be Fleischner sign, in which there is widening of the ileocecal angle, okay, in which there is gapping of the ileocecal valves, right? Then you have the inverted Fleischner sign is also known as inverted umbrella sign, ठीक है. Then you have goose neck deformity, that is due to the widening of the ileocecal angle, right? And in gastric ulcers, these are of two types, benign and malignant. In benign ulcer, you will see Hampton's hump, and in malignant ulcer, you will get the meniscus sign, right? So patient presented with abdominal distension, and pain. Okay, abdominal radiograph, erect view is shown below. What is your diagnosis for this case? Anyone, guys? Very good. So guys, in this image, very good, Dr. Shubham. So in this image we can see that there is free gas under the right dome of diaphragm. So that is seen in patients with pneumothorax, right? Oh, sorry, pneumoperitoneum. Now what will you see in intestinal obstruction? In intestinal obstruction, you will see that the loops will be dilated. So the caliber of the small bowel loops is more than 2.5 centimeter. Caliber of large bowel loop is more than 5 centimeter. Okay, they are considered dilated. Or if the cecum is dilated by more than 9 centimeter. Okay, then you consider it as a case of intestinal obstruction. And in the last image, guys, we can see that there is a thickening of the appendix. So the outer wall to wall diameter is more than 6 mm. Patient will present with pain in the right iliac fossa, right? So the first investigation in this case is that of a ultrasound. So other important signs which you should remember in pneumoperitoneum is football sign, radiolucency within the esophagus, ठीक है. Then you have cupola sign, gas under the central tendon of diaphragm. You have falciform ligament sign. Air, when air is lining the falciform ligament, you have your irregular sign. When both the outer as well as inner walls of the intestines are visible, of the loops are small bowel loops are visible, that is known as your regular sign. You should also tell me what is regular striate, right? And last is the liver edge sign, ठीक है, liver edge sign, ठीक है. So guys, these were few important questions in radiology, ठीक है. अभी मैं आपको कुछ images भी दिखाऊंगा, important images, ठीक है. So जल्दी से let us discuss few important images that can come in your upcoming exams, ठीक है. So let us begin with the IVP images. ठीक है. So IVP images are very important for your exams. So this is your J-shaped ureter seen in retrocaval ureter. Okay, hook-shaped deformity of the ureter. This is in retrocaval ureter, hook-shaped deformity, right? In the second image, we can see that there is dilatation of the distal ureter, giving the cobra head appearance. These are seen in patients with uretrocele, right? In the third image, we can see there is dilatation of posterior urethra, giving the keyhole appearance. So this keyhole appearance of posterior urethra, this is seen in posterior urethral valve. ठीक है, posterior urethral valve, cobra head appearance and retrocaval ureter. Now talking about few imaging appearances of the bladder. So the first one is your neurogenic bladder. In this you are going to get a Christmas tree appearance. ठीक है. And in the second image you see that the shape of the bladder is pear shaped bladder. So this pear shaped bladder, guys, this is seen in patients with pelvic hematoma, ठीक है, pelvic lipoma, ठीक है. These are two important conditions in which you are going to see a pear shaped bladder. Now talking about few important renal tumors, ठीक है, इस पर भी direct question आ सकता है. So the first image, it is giving you the central scar sign. Okay, so here this is a homogeneously enhancing lesion that is seen to arise from the left kidney and it is having this central scar appearance. ठीक है, और this is seen in patients with renal oncocytoma, right? Now this second lesion, we can see that it is this lesion, it is containing fat attenuation contents. So when the lesion is having fat attenuation contents and there is surrounding hemorrhage, so this is seen in patients with angiomyolipoma, ठीक है, and it is associated with hemorrhage also. When it is associated with hemorrhage, it is known as Wunderlich syndrome. Wunderlich syndrome. ठीक है, few USG images in obstetric section. So the first is a frog eye appearance. This is seen in patients with anencephaly, frog eye appearance, ठीक है. Lambda shaped appearance of the intertwin membrane. Lambda shaped appearance, this is seen in patients with dichorionic diamniotic twins, ठीक है. And T-shaped appearance, okay, this will be seen in patients with monochorionic diamniotic twins, right? So you have this double bubble sign seen in jejunal atresia, triple bubble sign in. So you must have seen these appearances on the X-ray. I am showing you these appearances on the ultrasound. Okay, triple bubble is seen in ileal atresia, and along with that you will see that there will be polyhydramnios in these patients. Right? Now, few fruit shaped appearances of the fetus. Okay, you have the lemon shaped appearance of the skull, and you have banana shaped appearances of the cerebellum. So this is seen in patients with anyone banana shaped appearances of cerebellum or lemon shaped appearances of the skull, seen in Arnold Chiari malformation, right? So cystic lesions, okay, within the brain, है ना, with an eccentric scolex. This is seen in neurocystic You should know the various stages of neurocystic also. Okay, Escobar staging system is used, and you should know that there is no edema in the colloid stage and the last stage, that is your calcified stage. Second image, here I am showing you that there is periventricular calcification, and this periventricular calcification, it is seen in patients with CMV encephalitis. CMV encephalitis. Hummingbird shaped appearances. Hummingbird shaped appearance of the brainstem. This is seen in patients with progressive supranuclear palsy. ठीक है, ये सारी appearances of the vertebra we had already discussed. Inferior beaking of the vertebra was seen in Hurler syndrome, right? Central beaking of the vertebra is seen in Mori-Kuo syndrome, and bone within a bone appearances. Yes, so actually this is an overall appearances. In progressive supranuclear palsy, though there is atrophy of the midbrain, पूरी appearances इसकी जो है वो हमारी हमिंग बर्ड की है ना, बट प्रॉब्लम सिर्फ मिड ब्रेन में ही है, atrophy of the midbrain only, right? So the ratio of the pons to the midbrain it increases, ठीक है, उसके कारण से पूरी अपीयरेंस जो आ रही है इसकी वो हमिंग बर्ड की आ रही है. Bone within a bone appearance is seen in patients with osteopetrosis. Bone within a bone appearance, ठीक है. So now कुछ आर्थराइटिस के important X-rays in arthritis, which again can be asked in your exam. So the first one is your licked candy stick appearance. So this licked candy stick appearance is seen in leprosy, ठीक है, in patients with leprosy, in patients with syphilis, and this is your neuropathic joint. Neuropathic joint, ठीक है ना. Because of the loss of sensation of the foot, there is consistent trauma, there is destruction of the bones, there is dislocation of the bones, there is disorganization of the bones, there is distension of the joints, there is debris within the joint. Okay, so this is your neuropathic joint giving the licked candy stick appearance, seen in leprosy, syphilis, diabetes mellitus, staph dorsalis. ठीक है. In the second X-ray, we can see that the patient will present with pain in the first great toe, okay, first toe, and pain will be in the night. Okay, so this is due to the increased level of uric acid that results in gouty arthropathy. So the most common joint that is involved, it is your first metatarsophalangeal joint, in which you will see that there will be rat bite erosions. ठीक है. And in the third X-ray, you will see that there will be erosions of the metacarpophalangeal joint. There will be osteopenia. Okay, so this erosions, and within the carpal bones you will get this spotty carpal sign. Spotty carpal sign. This is seen in patients with rheumatoid arthritis. Okay, so you should also know what is swan and neck deformity. In swan and neck deformity, there is hyperextension at the proximal interphalangeal joint, and there is flexion at the distal interphalangeal joint, right? Bone mets, again few questions are asked, ठीक है. So there is destruction of the pedicle. This is your owl eye sign, ठीक है. When there is destruction of both the pedicle, this is your blind vertebra, destruction of both the pedicles in metastasis of the bone. in which there is expansion of the, there is blowout mets seen in patients with thyroid cancer and renal cell carcinoma, and focal destruction of the cortex of the bone. This is your cookie bite mets seen in lung carcinoma. ठीक है, lung carcinoma. Hepatobiliary में again important images. Okay, you have this central scar sign seen in patients with focal nodular hyperplasia and fibrolamellar variant of HCC. ठीक है. If I talk about hepatocellular carcinoma, what are you going to see in hepatocellular carcinoma? You will see that there is enhancement of the lesion during the arterial phase. So these are arterially enhancing lesions, okay, that are showing washout on the venous phase. So this is typical of hepatocellular carcinoma, right? Now these are the MRCP abdomen images, again can be asked in your exam. So in MRCP abdomen images, what happens? Your CBD, your CHD, gallbladder, intrahepatic biliary radicals, these are very well seen, right? So here in this image, in the second image, we can see that there is cystic dilatation, okay, of the common bile duct. Okay, so this is the case of choledochal cyst, cystic dilatation of the common bile duct. This is the case of choledochal cyst. So you should be clear with the Todani classification as well. Okay, and type 5 is your Caroli's disease, in which you will see that there will be a cystic lesion, and surrounding that cystic lesion will be a portal vein radical, right? So here in this image you can see that CBD is dilated, and along with dilated CBD you can see that there is a hypointense filling defect within the CBD. So calculus is seen within the CBD. This is your CBD stone. This is the case of choledocholithiasis, right? So few important images of the kidneys which are being asked. Okay, so when the lower poles of both the kidneys are fused, this is your horseshoe kidney. When the lower pole of one kidney is fused with the upper pole of other kidney, that is your cross fused ectopia. When the upper poles and lower poles of both the kidneys are fused, that is your pancake shaped kidney. ठीक है, pancake shaped kidney. ठीक है. So guys, this was all about radiology. Okay, few important images as well as questions within the radiology. I hope this was a short session and you guys enjoyed it. Okay, so guys, if you have any doubts, you can always reach out to us. If you have any doubt regarding your preparation, again you can message us, you can message me. Okay, so till then guys, bye bye, take care, keep working hard, keep studying. Okay, and बस अपना काम करते चलो, अपनी मेहनत करते चलो. Rest, leave it on God, and if you have worked really hard, if you have given your hard work in the right direction, okay, good things will definitely come to you. So this was from my side. Bye bye, take care, all the best.